Well, first, welcome to our Research Alliance members. You've so faithfully attended our webinars over the last few months, and I hope you're continuing to find them of interest, and you know we're always open to suggestions. So you'll type your questions into the chat box. My colleague Terry will save them for the end and share them. If you're dialing in by phone, you can hit *6 when we unmute the phones. Our guest speaker today is Dr. Tom Frieden. As I said, he needs no introduction. He's the president and CEO of Resolve to Save Lives, an initiative of Vital Strategies. He is a senior fellow at the Council on Foreign Relations, and many of us know him as the director of the CDC from 2009 to 2017. He joined the CDC after serving as commissioner of the New York City Health Department. Dr. Frieden, over to you.
Thank you. I'm just struggling with this technology. I think if it's not Zoom, we don't know it anymore. But
Right.
Since I'm not on camera and since I just bicycled a couple of miles to get here, I will take off my jacket and start the presentation.
Very good. Thank you.
I want to talk about COVID, and I know we want to go quickly through COVID and get to the concept of the health defense operations approach that we have suggested. So let's go to the next slide. This is the bottom line. This is my challenge to Research America. Will you support a balanced portfolio of research that spans basic to operational across a range of agencies to achieve the maximum possible health benefit? And I will be blunt, I don't think this is what has been done so far. Next slide. Just to spend one moment on Resolve to Save Lives, after leaving CDC, I started this initiative at the home of Vital Strategies. We have two separate efforts. One is to improve preparedness for epidemics, and the second is to prevent 100 million deaths from cardiovascular disease. Our riddle is how does 50 plus 30 plus 0 equal 100? If we can increase blood pressure control from 14 to 50%, reduce sodium intake by 30%, and eliminate artificial trans fat, that will save approximately 100 million lives in the following 30 years. Next. Hypertension is the leading risk factor for preventable death worldwide. It kills more than any condition and more than all infectious diseases combined. Next. And hypertension is what will save the most lives. And I'll come back to this at the end. It does have a relation to COVID. Next. Our approach to improving hypertension care everywhere, including the US, is simple, practical protocols. And I'll say, as an internist who's worked for decades in various areas, it has been shocking the degree to which optimization of antihypertensive protocols has not been done the way it's been done for conditions like tuberculosis and HIV. Medication supply and equipment supply, team-based care, patient-centered services, and information systems that actually work. Next. As you know, COVID is a long-term threat to public health. It's the most infectious, most disruptive infectious disease threat the world has faced in a century, and we continue to risk explosive spread until there is a widely available, safe, and effective vaccine, which could be months or years away. When we look around the world, and we work in nearly 100 countries at Resolve to Save Lives, we see that places guided by and that fully support public health have less disease, less death, and less economic devastation. Next. This is an important slide. I'll just spend a minute on it because it's not widely understood. This is the Pandemic Severity Assessment Framework. It's used for influenza, but we've applied it here to COVID in the red boxes. And what you see is that for people over the age of 60 or with underlying health conditions, this is as bad as the 1918 pandemic. For the 0 to 19-year-olds, for kids, it is more like a flu season, kind of an average flu season. And for the 20 to 59-year-olds without underlying conditions, it's somewhere in between. This is very important to understand in terms of our response. Next, please. There are really important research questions. What is the epidemiology of transmission? Where is this spreading? If we knew that, we could close those parts of the economy and open others. We need to know whether mutations are associated with different severity or infectivity. We need to understand the optimal interventions that will reduce spread while limiting economic damage. We need to much better protect healthcare workers. More than 80,000 healthcare workers infected in this country alone, with more than 400 deaths. Just an outrage. We need to understand the length and strength of antibody immune response, the possibility of reinfection, and the level of protective efficacy. And of course, we need treatment and vaccine effectiveness. Next. What we find is that in a public health emergency, public health must guide us forward. Support for public health means sustained funding, a public health approach and metrics, and public health messaging. Meaningful surveillance to determine where and how the virus is spreading in each community, including trends in excess mortality as a fail-safe to know what's really happening, not only with COVID, but to other conditions that might kill more people because of COVID. We need smarter, more nuanced restarting based on risk. Schools and workplaces have different approaches, outdoors versus indoors, different group sizes, continued mask use. We need what we call the box it in approach, with testing, isolation of cases, contact tracing and quarantine, and global solidarity. A global pandemic requires a comprehensive, coordinated global response. Next. This is the box it in approach, to test strategically, to isolate all infected people, including in homes, as well as better isolation in hospitals, nursing homes, jails, prisons, homeless shelters, meatpacking factories, and other places where this can spread rapidly. We need contact tracing to find everyone who's been in contact and warn them. And we need quarantine for 14 days after exposure, with supportive quarantine and incentives, care packages, resources, and financial support for those quarantined as needed. Next. Everyone should follow the 3 W's. Wear a mask, wash your hands or use hand sanitizer, watch your distance. Next slide. Alert level systems can be very helpful. They can empower the public, increase accountability, and accelerate progress. We don't see them used in many places. Next. I will say they've been used in the best performing places like Singapore, New Zealand, South Africa, but not in many places in the US. Utah has used them some, and some cities such as Dallas have as well. We're seeing persistent inequality in health outcomes with racial disparities that are stark, persistent, and unacceptable, and are a symptom of broader structural, systemic, social, and economic inequities. And a disproportionate burden requires a disproportionate response. Native and Black people have about 5 times the rate, and Hispanic and Latinx people about 4 times the rate of hospitalization as whites. Next. Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. Next. We need to transcend false dichotomies. It's not closed versus open. We were never fully closed and won't be fully open until there's a vaccine. This is about a dimmer dial, not an on-off switch. It's not health versus the economy. Economic downturn is deadly, and protecting health is not interfering with economic recovery. It is the route to economic recovery. The 2 arms of the response are to start safer with the 3 W's and to box it in with the test, trace, and isolate strategy. Next. Yogi Berra said, if people don't want to come to the ballpark, how are you going to stop them? We're not going to be able to reopen the economy with the virus spreading. Next. You need look no further than Arizona and Texas to understand that. Public health is the road to recovery. Getting the economy started again will require better control of the pandemic. States and countries that have been guided by and fully supported public health have done better. Fewer infections, fewer deaths, less economic disruption. This is not about health versus economics. It is valid to adjust activity based in part on economic and social factors. And at Resolve, we have been saying this for months. Next, please. Now, we need to address the needs of COVID-19 and beyond. Much better infection prevention and control in healthcare settings. Broadband internet needs to become an essential service for all, and it should be freely available. We're seeing major internet disparities. Reorienting healthcare to primary care, including scaling up telemedicine, team-based care, and financial incentives for prevention to preserve and improve health. Sustained funding for global health security to tamp down the spread of COVID-19 and protect our health defenses. And CDC and state and local health departments need sustained support. Next. Global health is crucial. Stronger there, safer here. Despite progress, the world remains unprepared for epidemics. Sustained funding is needed to strengthen core public health programs and essential health services, both in the US and globally. We need to improve our ability to find, stop, and prevent health risks. Global health security means stopping disease spread when and where it emerges, so we are safer here. Disease threats are increasing in frequency and severity. Increased interconnectivity means that disease can travel from any part of the world to anywhere else in 24 hours. Next, please. This is the Prevent Epidemics map of the world. You'll see there is not a single country that's green in Africa, and essentially not one that's green in most of South Asia. Next, please. This is the approach to filling gaps globally. That tiny grid that you see is a summary by country of capacities. And all of those red areas and yellow areas need to step up. Stepping up is a key concept. This is one tiny box in one country, what that would look like. Identify pathogens, assess data collection, train staff, check data quality. There are approximately 10,000 life-threatening gaps. It's going to take a decade to close them, but we've got to start now. Next, please. Keeping America safe now and in the future. Tony, my friend Fauci, said never again. We should never, ever be unprepared for something as catastrophic as what we are going through now. The US public health system has suffered from years of underfunding. We need creative solutions to prevent, detect, and respond. We cannot afford another multi-trillion-dollar pandemic, but we can afford the health security that would prevent it. Next. HDO, or Health Defense Operations Funding, is to ensure America's long-term health security. Supplemental funding is a Band-Aid. There's a boom and bust cycle. We've experienced this with H1N1, Ebola, Zika, and now with COVID-19. Let me tell you, as someone who has run an agency, it's not possible to build optimal, sustained programs with one-time funding. You can't hire the right staff. You can't hold contractors accountable. You can't establish multi-year partnerships with organizations and countries. The future health and economic security of our country is best achieved by a permanent budget cap exemption for clearly defined public health functions, sustainable baseline appropriations for both global and domestic programs. Next. HDO can protect America's future. It's only applicable to core programs. I want to emphasize to this audience especially, we've been advocating for this in Congress, and one of the major objections is that it's based on the OCO, the Overseas Contingency Operations. The OCO did some very good things for the military. After 9/11, there was an influx of resources, and OCO prevented the kind of budget cliff that often happens after a supplemental. So it allowed the military to continue keeping us safe. But it was a slush fund, and it was seen as a slush fund. And so it is clear that it would be a non-starter to try to have this for an entire agency, any entire agency. That is not the way to push for this. The way to push for this is specific budget lines that give Congress the authority to look specifically and allocate for specific PPAs, as they're called in budgetees, programs, projects, and activities with specific accountabilities to avoid the critique that it's a slush fund as the OCO is critiqued. We suggest that these programs be required to submit bypass professional judgment budgets. This is done by the NIH Cancer, HIV, and Alzheimer's program, but it would give appropriators full control over amounts and oversight. Congress shouldn't have to choose between defunding Head Start and funding public health, or funding research on Alzheimer's, which is crucially important, and stocking influenza strain vaccine viruses. We have to stop looking at public health as a nice to have. It's our health security and health defense to prevent the next pandemic. Or as Tom Cole says, it's a no-brainer to spend billions in order to save trillions. Next, please. I'll end as I started. The challenge to Research America: will you support a balanced portfolio of research that spans basic to operational across a range of agencies to achieve the maximum possible health benefit? Thanks so much for listening.
Thank you, Dr. Frieden. I will jump things off with questions, but we encourage you, and I believe we have a few, but to submit your questions in the chat box. I know that in May, you testified on the Health Defense Operations Bill in front of the House Labor HHS subcommittee. How did that go? What progress has been made for those of us who may not be following this initiative closely?
On the one hand, it was very well received by both Democrats and Republicans. Tom Cole has been saying for years that you're much more likely to be killed by a pandemic than by a terrorist. And lo and behold, that's exactly what we're seeing. The next step is to try to get bipartisan support in the Senate, and getting support from the current majority has been challenging, because the concept is we're spending too much, we need to stop spending. So we're looking for a Republican champion in the Senate to move this to the next step, to be perfectly blunt.
Well,
we have had wonderful support, I will say, from former Senate Majority Leader Bill Frist, who was one of the main movers of this. There was testimony in the Senate earlier a few days ago, and there was very positive review of this. I think one of the real barriers is the idea that it's repeating something from the OCO that was objected to. That's why it's so important that it be PPA specific, not agency specific. Agency specific would kill this proposal. And then the second is just the politics of more spending at this particular time.
Thank you, Dr. Frieden. Terry, I'm going to turn to you.
Yes, we have questions coming in, and I'll remind folks that they can type them into the chat box. First question: how are we doing on the box-it-in approach so far in the U.S. in your view?
We are a laggard. We are lagging countries from all over the world: Iceland, Germany, Uganda, Rwanda, Ethiopia, Nigeria, Singapore, China, New Zealand, Australia. All of these countries are ramped up. A tale of two countries: South Korea and the US both had our first cases on January 20th. There are 30 to 40 cases per day in South Korea, and they are urgently clamping down and stopping them. There are 30 to 40,000 cases a day in the US, and we're not yet taking much effective action. If you had moved from the US to South Korea on January 20th, you would have been 70 times less likely to get killed by COVID. So I think there are states doing a better job, but we are connected. And the fact that we have explosive spread in Arizona, Texas, Florida, South Carolina is very problematic. Every week on Friday night, I summarize where we are with the pandemic on Twitter, and then I post that on LinkedIn on Monday. And so you can see a granular detail. I suggest as two really good websites are CDC's, of course, which has gotten more than 1.3 billion hits through this pandemic, and has a COVID view, which comes out Friday afternoons. It doesn't give enough detail state by state. I suspect that's because they're not being allowed to. They have some of that detail. So we at Resolve have worked with a terrific group of volunteers who have created a website called covidexitstrategy.org. And that has a few different tabs, and we'll be having more in the coming days to weeks. That's really useful to look at what's happening state by state.
Great, and I have tons of questions coming in now. This is great. How do you propose, you mentioned this a little bit, how do you fix the state by state, county by county kind of patchwork control of public health? In many cases, currently CDC has to be asked to come in by the state.
Yeah, it's a great question. I don't know that there's a quick or simple answer, but I do think that we have a federal system here. We have a failure of federal leadership. I don't want to say too much because basically I'm a scientist, I'm an epidemiologist, I'm a physician, and I try to stick to the science. But I can tell you that the science of responding to an emergency has not been followed by the federal government. So that makes it even harder. It's hard enough to do this state by state, but without really detailed guidance, direction, facilitation from the federal government, it's really difficult to happen. I don't have a good answer for what do we do when the federal government isn't doing what it needs to do. I think one of the things that we can consider is pushing more, and this is why I pushed people to the covidexitstrategy.org website, to have every state have a minimum of certain indicators that are tracked openly, so that it's apples to apples. If you look on the 50 websites of the states, it's letting 50 flowers bloom. And we'd really like to be much more specific about that.
And another question, can you elaborate on what balanced means in regard to the federal government's role in research? Are you saying less should be spent on science and more on implementation?
I think that research shouldn't mean NIH. Research should mean a combination of NIH as the lead research agency, but also FDA, CDC, and other parts of the federal government, including BARDA, and even out of HHS in the Department of Agriculture. All of this has to do with health security. And then within research, I think we need a much broader portfolio. I think we have a major gap in implementation research. And NIH is the huge source of funding for research in the US, but I really wanted to emphasize the hypertension issue for a minute, because I'm shocked about it. I'm a tuberculosis doctor, and for decades, we've known how to treat tuberculosis. Hypertension is the leading cause of death in our country. It's the single best thing we could do with our healthcare system to save lives, to prevent heart attacks and strokes. We get that most important question right exactly half of the time. We have a 50% control rate despite spending $3.6 trillion. So that slide that I sent earlier, and you're welcome to have the slides and circulate them with those 5 components, it's been astonishing that we still don't know the best regimen. And it's not because it's hard to find out. It's because, quite frankly, they're all generic drugs. And so no one has done head-to-head comparisons from industry, and no agency has done the detailed studies. Even a very important question on one particular type of diuretic to use is only being studied now because the VA had a brilliant idea to do it while spending almost no money, using their electronic health record system and in a very creative way of allocating different groups. So what I mean by balanced is multiple agencies and a much broader view of operational and otherwise.
Great, thank you. Another question, looking at the US in green on your prevent epidemic slide, do we need to reevaluate the evaluation metrics? Do we need to rethink readiness and the international health regulations?
It's a great question. I'm sure the international health regulations will be rethought. One of the aspects that we've actually been talking about for a year or two is the issue of timeliness as one of the really crucial areas to look at with preparedness. Timeliness is crucial, and what we see in the COVID response is timeliness made all of the difference. Countries that timed this right were able to avoid the worst outcomes. Countries that didn't weren't able to. And that's what we need to focus on as one of the key areas.
Great. And a question about the HDO. Would the Health Defense Operations Fund be used solely for combating infectious diseases or other health areas as well?
I think we're most likely to get support from Congress by limiting it to health threats. I would focus on infectious diseases. I would leave it to Congress whether environmental toxins or radiological risks would also be there. I think probably, ideally, at least all three of those would be, because there are major potential disruptive activities and threats in those areas. But I would. That's one of the things I would leave to Congress.
Terry, I'm going to jump in with a question. Dr. Frieden, I'd like to ask you a question about vaccine trust and vaccine confidence. You know, you've seen the survey data. Our own surveys show a decline in those who are confident about vaccines. And a recent survey showed that only a slight majority said yes when asked if they plan to get vaccinated against COVID-19. What should we be doing now to ensure enough people are willing to be vaccinated against COVID-19 to ensure population immunity?
Well, let me answer that one, and then let me do a lightning round of the questions that have been answered, because I think we're supposed to stop around 2. Is that right? I can go on a little longer if you'd like, but I want to respect that.
We're happy to extend the time if you.
Let me be really quick. In terms of vaccines, we have to get the communications right. We cannot cut any corners. We have to have widespread media coverage of the ACIP deliberations. There was an excellent meeting last week. I don't know why it wasn't widely covered in the media, but we really need to have clear communications about this. We need to make sure that we cut no corners for safety. There's a real risk that rushing a COVID vaccine to market would not only result in low levels of COVID vaccine uptake, but further complicate all vaccinations. Can I do a lightning round? I'll just read through this. FDA and HDO. If FDA food is HDO, why not USDA food safety inspection? Absolutely. I think I mentioned actually agriculture. The only challenge there is it's different committees in Congress, so you have to be very careful about that. The HDO could certainly include other parts of FDA. I agree with that question. Diagnostics, therapies, and vaccines. Those are all also key in a pandemic. So total agreement with that friendly amendment. In terms of the discretionary cap, there's a question, discretionary caps from Richard. Nice to see your name there, Richard. Have limited investments. This is, and there's some suggestions of who we could try. So we are certainly looking for that. Interestingly, what we're hearing is the concern that either we won't have caps anymore, so we won't have to worry about it, or it's too much like OCO, which was a slush fund, or can we really afford this? And I think we just have to make sure that yes, we actually do need to do this. We can't afford not to do it. Question, should we be concerned about the end of the public health emergency classification? I would certainly think so. There's no doubt we're still in an emergency. And then why would the PJ budgets in the HDO make a difference? You say that the NCI PJ has made no difference. Well, I don't know, you may know better, but I do think that the budget dance, as I've seen it play out, requires agencies to go through an extensive process of getting chopped to pieces by OMB before the public or Congress sees it. So the combination of an honest statement of what's really needed and a cap exemption could make a really big difference. We have spoken to various people in the Senate. We have had support generally. And the last question here, how can listeners make sure that HTO becomes a reality? What can we do? Well, thank you. I think what we need to do is push all of our elected representatives to make this happen. Look particularly for the majority in the Senate. We need champions there. And then we need this to be part of the appropriations bill. It's kind of in the balance right now. I don't know that it will happen. I don't know that it won't happen. I know that if we don't make a go for it, it definitely won't happen. And so I thank and encourage everyone to do whatever they can on this. And if there's another question or two, I'd be happy to take it.
Well, Dr. Frieden, I'm going to take the opportunity to thank you for joining us today. And your message about the importance of supporting a broad portfolio of health research couldn't be more akin to what Research America and our Alliance members believe in. You know, from biomedical research to public health research, healthcare delivery research, regulatory science, et cetera. So we are certainly with you on that point. Thank you for all that you're doing, continuing to serve the public, even though you are now not in government. But we really were delighted you were able to join us. I'm going to make a couple of quick announcements. Someone asked Dr. Frieden about the federal public health emergency designation, and there was a letter being circulated by APHA and ASM, which you can sign on to, I believe, through the 4th of July. So you can contact Jordan Wolf at APHA or Mary Lee Watts at ACM. And then we also wanted to encourage you, if you haven't done so, to contact your House members regarding the bill to provide aid and research recovery. That's the bill led by Congresswoman DeGette and Congressman Upton. Next week, hopefully you can join us on July 9th at 4 p.m. for our next Alliance member call with Chris Austin, who's the director of the National Center for Advancing Translational Sciences at the National Institutes of Health. And I believe we also have Dr. Gary Gibbons, thank you, who will be talking to us about heart disease and hypertension. So right in line with what Dr. Frieden was talking about today. Again, thank you so much for joining us. We welcome your comments and suggestions, and have a good rest of the afternoon.